rabbit hole, I got the chance as an embedded human factors practitioner to go deep into the rabbit hole. So like many of our colleagues and some of the folks even at the Human Factors Transforming Healthcare Network, right? We are the folks that get our hand dirty, and I'll show you some of the things they've uncovered. Where am I? So KK Hospital, we are based in Singapore, and we are the only women's and children's hospital. Therefore, we became the de facto primary outbreak center for all the pediatric cases in Singapore. We had a National Center for Infectious Disease, and it had like dedicated 330 beds for infectious, emerging infectious disease outbreak. But we also had a mandate from the ministry stating that all the public hospitals will ward any suspected COVID-19 cases on site. This is to minimize contamination and transportation and the risks surrounding that process. Background on where we are. So as a reference point, Wuhan and Hubei was locked down on the 23rd of January. That was a day before the Lunar New Year Eve. In fact, from the context of China and even in Asia, the Lunar New Year is a huge festive season for all of us, and especially for China because it is one of the two major block holidays that which Chinese tourists would come out of China. And one of their popular locations to visit is Singapore. And what has we got our first case coming in on the 23rd? We started having this huge wave of Chinese tourists coming to our A&E and our children's emergency simply because they are already in our, on our island and they feel sick. Moving down the line, so we thought we managed it well. We had 2 weeks. In fact, all of the cases were all imported cases from China until the one local cluster, the first local cluster where it came from a shop that was interacting, that had Chinese tourists, right? So we had, I think, the first 4 cases of no travel history. Folks, we had no travel history, and soon after we declared DORSCON orange. And then basically we kind of saw a lot more clusters coming up locally. Where are we right now? The strategy has always been to contain and to mitigate. As an embedded human factors practitioner, I have 2 roles. Passively, I am the war journalist. I go down and I document the entire process. It is a 1 in 10 years, or if you count SARS, a 1 in 13-year event, or 1 in 19-year event. Anyway, so it was rare. And I wanted to document all that we have done for this outbreak. Actively, as a human factors practitioner, I help to solve the problems as they appear in front of me. I am the link to the C-suites. I report directly to the chief medical officer. That's my role. I get assigned, incidentally, I get assigned this responsibility of ensuring that the staff has high morale, because typically in outbreaks, we do see very challenging situations. All right, so what I'm gonna do for the next 10 minutes is just to share some of the war stories. I broke it down into the macro, the meso, and the micro level. And if there's any more time, I'll talk briefly about the patient's perspective. Starting with the macro, this is us. We are a public hospital, so most of our wards are shared. We try to care for the general public, which means that a lot of our services are subsidized. We have 1 dedicated isolation ward with 18 beds. And clearly that is not enough, right? If you're talking about an emerging infectious disease outbreak, we needed to create more room. And the more room isn't for the actual cases. Really, what we're trying to do is to contain all the suspects. What we've learned from SARS was we did not arrest the suspects early enough, and we allowed the spread to occur even within the hospital. So there were at least 1 or 2 super spreader events that happened within the hospital, and SARS was scary for us. We lost a few doctors. We lost a few doctors due to that outbreak. So here we were not blessed. We're not blessed like the National Center for Infectious Disease that was designed specifically for an outbreak. So what we had to do, we had to decant all the private room wards. So all the, the private wards where you get to pay a premium to stay in a private room, we decanted the patients so that all the suspect cases were kept within common locations. We had to create more rooms, and in order to do so, we took over some of the clinics. We basically parked them somewhere else. We turned the consult rooms and even the dental rooms into private rooms, isolation rooms, basically with positive with negative air pressure. Right. With that, we were able to generate upwards of 50 beds in preparation for the suspect cases. What you don't see really in terms of numbers are the suspect cases. These are the ones that really, really stretch the system. And again, because we are running on the containment and mitigation strategy, we were trying to make sure that we stay ahead of the virus and the outbreak. That meant a few things, right? That meant that the teams, as part of the business continuity planning, we had to break up into teams so that they don't cross paths. We had to have shifts so that there's always a team available, readily available. So with 12-hour shifts, our doctors we had more doctors staying behind in the hospitals. We needed to find space for them to rest, right? So you could see the traditional on-call room used to have one bed, now is a bunk bed. We turned one of the training rooms into a dormitory. Even the consult room in the ward has a bed in case the doctor was working late, right? And this is the heart of the whole macroeconomics, right? When you talk about resilience, for resilience to be successful, it requires resources. Resources across all the major components of the social technical systems, right? We needed nurses, so in order to free up the nurses, we had to cancel electives. We brought down nurses from the O&G department, so they were to some extent they were excited because they were able to practice their pediatric skills over again. We clearly needed more equipment, so there still is all this talks about lack of masks or the supply of masks. We really have a good supply of masks, but it's good to ration. Oh, I'm seeing something. There's extra work involved. The specimen dispatch, for example, when you're doing a blood, you're doing a swab, we can't use the pneumatic tube anymore because if the container was to break, if the tube was to fail, you have a hard time decontaminating the entire pneumatic tube system. So we had to have porters, extra porters to help deliver the swabs down to the labs, amongst many, many other things. But the heart of the message is that if you want to talk about resilience, you want to be ahead and stay ahead of the curve. To be successful, you really, really need to free up resources like what Terry said. Oop. Moving down, we talk about the teams working together. This is an actual code blue. And typically in a code blue, in a resusc situation where there's patients crashing, airways an issue, you have multiple different teams rushing down. In this case, rushing down to our isolation unit to care for that one young patient. Right? You have the intensivists, you have the potentially the airway team, which are usually made up of this, and you have the pediatric medicine team who are working the crash cart. So you can see what happens here in this case. Everyone went down. As a war journalist, I ran down. Everyone's trying to dawn quickly. People are helping one another to dawn. Here you see in the bottom left corner, the pediatric medicine team preparing all the relevant drugs. And you have the folks preparing to go into the war zone, right? The intensivists all geared up going in. One of the key challenges we faced was you have all this multiple expertise and everyone looked the same. You can't tell the nurses from the doctors. You can't tell who this doctor is. You can't tell if this is a senior doctor, junior doctor. You see the anesthetist. Is he supposed to be out here or in there? Terry talked about communication. Communication is a common trend. It's a common thread throughout the entire COVID-19 episode. in this particular context, it's really hard to communicate when your mouth is muffled by all these masks. And then on top of which, when you're stuck within the isolation room, you're separated by 2 doors and an ante room. How do you relay message between the patient's bedside and, in our case, the crash cart, which is located outside? We didn't want to contaminate the crash cart, so we kept the cart outside, and we just prepared the drugs and send them down line. So, you know, again, this is where I wear the problem-solving hat, right? So one of the things that we have done before for a trauma code, in this case, where in the children's emergency, we came up with labels of all the players of the game, right? In the trauma code, you have multiple different players. You have the surgeons, you have the emergency physician, you have potentially a neurologist, neurosurgeon, the anesthetist, and then plus all the intensivists and all the nurses that come with them. What we did was we learned from, you know, there's so many examples, right? In the naval context, the aircraft carrier, everyone was properly labeled. You had Rob, the anesthetist, who labeled his cap. So maybe what we could do at least as an interim measure or just prototyping is to come up with a sticker to just label and identify all the players in the isolation code blue. There were lots of tools for safety, right? We brought in the video Laryngoscope because we wanted to make sure that the patients, or the distance between patient and the airway physician was kept further apart where possible. Right, so this was new tools that we brought in to make sure that to improve our ability to stay safe. But with all the tools that come in, right, that kind of affected the way we manage them, right? So one of the key findings, or one of the key recommendations we've heard, is to protect our eyes, right? Because there was, you know, droplets and aerosols could get in through the eyes. So one thing we had to do was to protect our eyes. We had a supply of disposable eye shoes, the same eye shoes that you use in the operating theater, but, you know, the supplies were running low. The surge was coming in. Every patient, we used one, we threw one away. What we ended up doing was to supply each individual with a safety goggles, right? That meant, you know, that the care provider had to disinfect it after visiting a patient. They didn't come with a proper Ziploc bag or a way to store the clean and sanitized safety goggles. So for a while, we were using inappropriately sized Ziplocs, right? So even if you could seal up the bag seal up the goggles in the bag, where do you place them? You know, this is a new equipment for us. We have limited number of pockets. Every time you care for a patient, you have to don your mask and your goggles. So, you know, you have to carry it around. So this was one of the many, you know, challenges on the ground that we are trying to resolve, or at least work around to make it happen. Which leads us to what our individual folks are facing, right? Suddenly you're required to recall how to don the positive air pressure respirator. So I think Aisha alluded to this. It's not so much the donning, it's really the doffing. There's so many different ways for you to forget any crucial step, and then you would contaminate your colleagues. There's so many ways for you to, you know, to do something wrongly. I was practicing my PAPR, and I was doing my doffing procedure. I rolled the infection gown, the yellow gown, on my body, right? Because this is a typical instinct of mine. I started rolling out, and I was, you know, the nurse trainer was warning me, saying, no, you're supposed to roll it away from you. And these are the things you're supposed to keep in mind as you care for your patients. There are many essential steps and lots of warnings, but then one of this misstep can be really, really costly, right? We talked a lot about, in one of our projects, we talked a lot about the role of the physicians when they're caring for our COVID-19 cases, the decisions they have to make under ambiguity and uncertainty. We started out really early, we kicked in our outbreak procedures while it has Wuhan, and basically the entire Hubei province was locked down. The information that we got was definitely imperfect. One of the stories we had was the physician, instead of using the case definition provided by the ministry, the physician used her gut feel, and as well as experience dealing with MERS, the Middle East respiratory syndrome. And she warded the suspect, and it turns out the suspect was positive. If you had followed the case definition, we would have released this individual into the community. So there was all this, constant dealings with ambiguity and uncertainty, and yet you're required to make a call. And the call has major impacts, right? Major impacts, not just medically, but even financially. We talked about, it's funny, we don't talk about the cost of the test. In Singapore, when you are tested for COVID-19, if it's based on the case definition set up by the ministry, then the ministry covers for the test. Right now it's priced at 250 Sing dollars per test. But if a physician decides that maybe this is a suspect case, doesn't really fall within the case definitions, but I really, really want to make sure that this individual should be tested, who pays? Do we just set up a costly booby bomb? We send a costly bill to the patient simply because we felt that the patient should be tested, right? There were a lot of practical influences as well. We had a patient coming in from another general hospital, and because I think she was pregnant, so she was routed to our hospital, and the ONG doctor was like, yeah, I think from a pregnancy standpoint, you're safe, but you really should get yourself tested because you're working in a healthcare setting. So she wasn't sure whether to send her back to the hospital, which is right next to the National Center for Infectious Disease, or to have the test done in our hospital. My senior consultant of infectious disease made the call and said, just test her here so that, if it's positive, keep her here, test it. At least, we reduce the risk of spreading as she travels from yet one point to another. But that was against protocol, right? The protocol was to only test any suspect cases when he or she has been admitted into the ward and isolated. So as you can see, there's all this work as done situations that are constantly happening throughout our episodes as we deal with COVID-19. On that final note, let me check on time. I'm so sorry. So I'll just briefly talk about this one. Nobody is ever fully prepared to be isolated. Oftentimes, what we have is you have a patient who is fluish, goes in to see a general practitioner or basic clinic. The clinic says, I think you should go get tested. Calls in, sends you to sit in the corner, calls up the ambulance, get you escorted from the clinic to the, in our case, to our hospital, for example, or to the National Center for Infectious Disease. And that's where they say, yep, I think you're a suspect. We're gonna start escorting you to the wards, right, to the isolation wards. And within the span of 1 hour or less, you are effectively locked up in the isolation ward, poorly prepared. You probably didn't bring your charger. You probably might have plans for the evening or even dinner sitting at home, but now you're not going home. You're stuck in waiting for your test to be done. And worse, if you are positive, you basically are suddenly locked up, and your life is thoroughly disrupted. So what we're doing right now, one of the studies that we are doing right now is to poll all our caregivers. So we work in a children's hospital, so all the caregivers who have to be locked up, I say as it is, that had to be locked up with their children. We poll them using simple surveys, and subsequently later on this month, interviews on their fears, their anxieties, how disrupted their life is because they were thrown into the isolation unit. I end with this picture. This is what I call the Wuhan mommy. She's a mom. She's traveling with a kid from Wuhan. There's a long story behind her. So I'm just leaving it here and say that if between when we get to Chicago for the annual meeting or Orlando or anywhere in between, if there's a chance to share the story about the Wuhan mommy, remind me and I'll tell you the entire story behind this poor mom. But that's it. This is my presentation. So do stay safe and do be careful with my photos. It is photos in the front line, and I do share it with good faith that it would help someone within our community as we battle the COVID-19. Thank you.
All right. Well, thank you, SQ. We are running a little tight on time, so we're just going to follow up with one kind of, we'll say, a compound question that addresses, I think, a number of questions several people asked. And that really relates to the success that Singapore appears to have had in sort of bending down the curve. And in particular, there was a question about how you determined, when to make these kind of increasingly intensive changes around room design, canceling electives, et cetera, especially initially when it wasn't clear how severe the threat was, and sort of related as how you dealt with the issues of healthcare providers going to home quarantine, which has been a problem in Italy. So essentially how Singapore has dealt with these things, especially from a human factors perspective.
So definitely one of the key themes here essentially is the resource, right? Spatial resource as well as the human resource. And what we have done basically is we had to look ahead. We knew who are the nurses that were back in China for the Chinese New Year holidays. We were really careful not to get ourselves quarantined, especially during the initial part. But what we then did was we started freeing up non-pediatric nurses. We just had to find means and ways to find resources. It's unfortunately the truth right now with many of our hospitals that in order for us to survive this DORSCON Orange, in order for us to survive this unpredictable surge, we had to make sure that our armory was filled up, our treasury is fed, that we had the ability to make those changes. So I have no prescriptions, I have no prescriptive recommendations as to how each of our folks should do it. I can only say that what we are seeing so far and what we're seeing success of, especially as an entire nation, is to find means and ways to get that resource.
Okay. All right. Thank you very much, SQ. And we're going to move on to Dr. Sachs. I hand off to Tony to introduce him.
All right, great. Thank you, SQ, and thank you, Eric. And next, another presenter on a time zone much later than we are here in the States, Dr. Hugo Sachs from the University Hospital in Zurich. And Hugo, go ahead and take over. If you want to show a slide, you could take over the screen sharing or just go ahead and start.
Yes, hello, this is Hugo from Zurich, and I'm happy to be here and share some of my thoughts. I'm an infectious disease physician, and I'm heading a group of around 30 people who are infection prevention unit. And we have integrated human factors as a principle in our work all the time, because since more than 10 years, I'm really believing that this is the way to go for infection control and infection prevention in hospitals. And usability design and usability thinking is a very important thing. Today, I would like to, well, I could give you some of the, some thoughts about where we are. We are very close to Italy. Italy has become the center of an ongoing outbreak, an epicenter of this pandemic. And Switzerland is very close. There is an Italian part of Switzerland, and people are going back and forth over the border. So the Ticino, the southern part of Switzerland, was involved in ongoing transmission very quickly. And it's also come to Zurich and to all the areas of Switzerland. So all what we heard before applies to Zurich as well. And what hit me most is, what hits me most is the dynamic of this outbreak and the dynamic of adaptations that we have to bring to the system, to the hospital system, to be always a bit ahead of the pandemic when we can. So I would like to sort of pitch for one theories and one theoretical concept that I think is really useful and that influences behavior of everyone, and that is also important for human factors design as a core principle. And I would like to suggest that it is also a thinking tool, and it's important for metacognition. I think the human factors community is quite aware that what mental models are, but I quickly gonna say something about how I see this concept. Mental models are fuzzy images in our head on how things work around us. When we look, when we see it in a very radical way, then our senses give us the information about our environment in a raw way. And we don't actually synthesize all this information to make sense of the world around us. It more or less only serves as cues. And then we download the images and principles that we have in our head as stored images, as fuzzy concepts, how things could work, and download them on cues and sort of paste them on reality. And what is important to realize in that is that we are mostly unaware that we are doing this all the time. And so mental models can see in a positive way that they save calculation power in the brain. We are very quick in just a few cues to understand what's going on around us. And so this saves calculation power. So if we would have to analyze all the time, all the sensory input and understand what it means, it would be very slow and it would need a lot of calculation power in the brain. But this also comes at a cost. If the cue is misleading and we download the wrong concept down from our memory and from our experience, then we can get it all wrong. And this pitfall is, and this has been mentioned in the talks before, is important in communication, and especially in the situation now where we have this very dense in time, very dense slots to communicate, and the communication has to go very fast across large populations. It's very important to be aware of this. And the pitfall is that if two people have different mental models of a situation, then they might talk to each other and they might think that they understand each other, but what one person says, the other triggers a mental model in the other person's head. And if these mental models are not aligned, they might not understand each other while they think they do. So, for example, this is very important in a situation where we talk about things that are not visible, like germs, like viruses and infectious diseases that also have a delay until they get manifest in a patient. And so, for example, we have argued in a recent publication that if you have just a very simple example out of infection control, if you have a bedside computer, and some people might think the rule is that this computer belongs to the patient's own, so there would be hand hygiene when you walk from outside and touch the keyboard of this bedside computer. And other people think this is not part of the patient's own, so you should do hand hygiene when you are touching the computer and then touching the patient. There would be, the computer would become, because of these non-aligned mental models, become a real hub for transmission, like a busy airport, like Chicago Airport, where some people come and put germs and the other people take it, and both think that they actually do a good and safe job. Now, for the topic of today, coronavirus, I think it is really important and very beneficial to have a metacognition of what everyone's mental models are about the disease, about how it's transmitted, and about measures to be taken. So, for example, and this is really interesting because looking into my own head over these recent weeks and days, I could see how my mental model of how the virus is transmitted and what that means for behavior, what that means for PPE, for personal protective equipment, has changed very quickly. So it has been very salient to me that I'm using mental models to talk to people and to decide what measures and what behavior is adequate. First, we thought maybe the virus spreads through the air a lot, and then we realized that probably it's not possible to have this luxury of thinking of SARS-2 as an aerosol, as an airborne disease. So we came back to the principle that it is a droplet transmitted disease, and could go down in the measures to be taken from FFP masks, from respirators to simple surgical masks for treating these patients. And this also was necessary because we cannot order enough respirators anymore. And so we had to change actually the mental model in people from one mental model that this is really something that you have to have an airtight mask around your face, to something that is spread by droplets that fall down after 1 meter, to be aligned, and so everyone felt secure with the PPE that we are providing. And the shift in mental models, especially across a large population of people in a hospital, is really of concern, and it's a challenge to design, to bring the right images very quickly into the heads of people working together across a hospital or even across a nation. So we used, and I think that is the recommendation in the design work, we used that everyone got together and shared mental models. This is true for my team. We convene every day and we talk to each other. So the mental models about the disease, about the measures to be taken, can be aligned. And we also do that across Switzerland, that we do phone conferences. And then when we have to shift the mental model of something, we have to change a practice, we do it together. So everyone is at the same place. You're probably aware that through the media always likes to have a very extreme images of people completely protected by high-level protective equipment, and then some people don't feel secure if they have a lower level of protection, even if the disease doesn't need it. Another problem of mental models is the mental models between administrators, politicians, and healthcare workers. So we in Switzerland, the epidemiologists and the physicians, we are much more looking ahead, and we are capable of already seeing the reality in 2 weeks, where we have the intensive care units full of ventilated patients and a lot of pneumonias in the hospital. This is an image we have in our head. We copied it from situations from Italy, from China, but the politicians, they have a completely different mental model of this disease. They look at what they see in numbers now, and they have a hard time imagining ahead. So they tend to lag behind with their decisions, behind the fact that the transmission is ongoing now and will sort of determine the caseload that we have in 2 or 3 weeks. And they're almost because of their wrong mental model of the whole epidemic, how it will evolve and how the disease is spreading, they are not capable and miss the moment now to decide on drastic measures again for social distancing. And we really have to bring to them in a kind of mental model design work almost. We have to tell them stories that they become a kind of availability of these images in their head, so they can change their mental models of what's going on right now, and they react in the right way. And the same is true for the public. The mental image that we think is correct is that the younger part of the population is not getting very ill, but they transmit the disease in the society, and the elderly and people with the disease will suffer and will have a very severe disease. And so the idea of slowing down the spread of the epidemic would actually involve young people not going to parties now, and to transmit this mental model of this whole epidemic and what it means to go to a party, what that has as a consequence for elderly people is really important. And we try to do this kind of design work on mental models throughout the society, healthcare workers and politicians. And I will close with that remark, and I'm happy to see if there are any questions.
Okay, thank you, Dr. Sachs. I think there are a number of questions, but one that's sort of interesting to me personally is this one about the human factors involvement with televised media and social media to help get concerns across. And I'm curious how that links to your comments about mental models. In other words, how do we shift people's mental models on a large scale? It's one thing to talk about the individuals, but across a large number of people, what can we do to get people to make that shift?
So I think it has been one of my insights since years that actually a good channel to even reach healthcare workers, but certainly reach the public, are the media. And it's a kind of skill and experience that we build with time and a network also to the media to know how to pull certain strings to get the media to report the right thing. It's almost also a design work that we are doing there by knowing what journalists like, and then give them this and put on that the right message, so they will act to actually do a good work in shifting mental models in the right way.
Okay, thank you. I think we're just a little tight on time. We'll have more questions at the end as time permits, but I'd like to shift back to Tony so he can introduce Dr. Perry.
Awesome, great. Thank you, Hugo. Thank you, Eric. Last but certainly not least is Dr. Shauna Perry. Shauna is in the Department of Emergency Medicine at the University of Florida's College of Medicine in Jacksonville. And Shauna, take it away, and thank you. Shauna, we're not hearing you yet.
How about now?
There we go.
Perfect. All right, let me reset
Thank
this. My apologies for difficulties here IT-wise. I'm probably a little tired from working a lot. Can you see my screen?
Yes, we see it. You can go, if you want to go into slide mode, well, you're fine this way, or you can go into full screen mode, either way.
I'm showing full screen here, so let's see why you're not getting that.
There you go.
You can see full screen now?
Perfect. Thank
Great.
you. You're great.
Yeah, so please ignore any coughing or sniffling that you hear. I do not have coronavirus. I have very bad allergies, which further complicates the mental model that Hugo was talking about earlier and has made my life on the front lines as I take care of other patients that much more difficult and frankly at times almost gut-wrenching. So I titled this brief few slides, Stuck in the Middle, observations from the clinical front line of someone who's living and trying to manage life for the lives of other people through a very difficult time that is novel to not only me, but to the health systems that I've been working in. I use that title from a song that's been playing in my head since I first heard that COVID was on the US shores. And it's a song from 1972 when I was only, of course, 5 years old. And the song was by Steelers Wheel. And you, please feel free to look it up and listen to it. And the lyrics actually seem to fit the sensation that I'm having now of being stuck in the middle of a very difficult situation. I am, little background, I am a practicing emergency medicine physician. I've been 23 years in practice. I currently work in 4 facilities in 3 states. So I've had the unique opportunity to be able to observe and participate in the work that's been going on for managing this particular infectious disease crisis. The 4 facilities I work in are either a combination of academic, urban, community-based, and rural. And there are no 2 organizations that I'm working within. None of their organizational cultures are alike. There are some very basic rudimentary components. Yes, there's an administrative wing with the CEO, CMO, et cetera. You have clinicians, certain departments, but it's a wide variety of resources available. And unfortunately, the opposite, resources not available, especially when, as we were talking earlier, I kind of wish I'd gone first because I think that would have helped support some of the talks that others have given. But I think ultimately it's about the fact that there's a significant amount of resilient and adaptive behavior that's going on behind the scenes, especially in the facilities who don't have the resources of the larger organizations like SQs in Singapore, like Hugo's, like Terry's. So that's my one hat is emergency physician. The other is I have a little bit of human factors knowledge and experience that I've developed over the years. And I am facing my first real gigantic pandemic. It's one thing to say there's been a flu epidemic, but this will be my first pandemic. And I realize I have a very unique stance at this point, that I'm a clinical worker constantly already working in a resilient setting of an emergency department. 4 different emergency departments that each ask for different things from me and require different degrees of adaptive behavior. And then on top of that, I'm being asked to further adapt to a new threat. And I periodically find myself having an out-of-body experience as an observer because I'm fascinated by the human factors issues that are existing and the ones, as Hugo was describing, projecting ahead to what the next level of problems are going to be. Again, I'm keeping it very brief because I think the questions are most important. I wanted to at least give a brief model, and this is the simplest I could come up with in a short period of time, of what the landscape looks like in each of these sort of overall from my perspective as someone in the trenches. And it is that there is tremendous pressure in the States on every organization to deal with this in a way that will, as you see on the far left of this SEEPS model, minimize, its focus is on outcomes, making sure that there is a limited number of deaths. We know that there will be some from a clinical standpoint, but the pressure is to mediate, to control and suppress that number or flatten the curve, as Tony said. Plus, there are also additional financial, as we see from our stock market here in the States and around the world, ramifications as well that we also are sensing and feeling. Even though we don't have as much one-on-one direct responsibility, we know that we as clinicians contribute to that. So the large arrows are just to demonstrate the external pressures and sort of how it's being viewed or how we feel it as the folks on the front line. And that those pressures, as you can see at the top, where I've listed some of the external pressures from the population, from the government, from the media, et cetera, are being placed on healthcare organizations that are then promptly shifting it to the persons at the front line. It's on the workers to try to make these policies, programs, suggestions go. That is requiring us to have, as you can see the arrow going to the left, the tools, technology. There's been no time for training because many of these smaller facilities, especially in community settings, were aware but didn't have the resources to address a lot of these issues up front in a pre-planned or succinct methodological or scientific way. They literally are going, situation to situation because of a lot of their other external pressures regarding financing, staffing. I work in one facility where a third to a half on any given shift of the ED nurses that I am working with have graduated within the last year from a nursing program. That definitely impacts. So their mental model is totally different than someone who's a PGY-23 like myself. And they're working from a very different posture and actually looking to, and not clear where to look for leadership and direction. More importantly, they just don't have the history, medical history, or professional experiences to be 100% certain of how to navigate this. So I thought that I wanted to highlight two pieces from this, and that is that what I'm seeing is lots of pressure, more pressure on the person in the form of emails. There's some tool development. There are attempts to modify existing tools, devices, access, but many of the institutions are not as IT advanced as others. There's still some settings that I have heard of from other colleagues where they're still getting most of their information actually as newsletters and leaflets because their email system is not as robust internally, and they're actually having to communicate, in the departments with paper mediums and materials. But the two areas where I think the greatest emphasis should be, but isn't, has been in understanding the process of care that is already occurring in order to figure out how to integrate effectively the measures that we absolutely know we must do in order to contain this thing. And what kinds of tasks are now being either complicated, supplanted, or put in direct conflict with what we know is going to be the most important practices that are not just an issue for my patients on my shift in my ED, but that I'm working that day, but actually have ramifications well beyond the borders of the United States and implications for healthcare, around the globe. So what I thought I would do, and I condensed this significantly once I saw we were short on time, is I thought I'd give three quick examples of what some of the local rationality, which fits right, I think, into some of Hugo's brilliant discussion about the mental models that we're all struggling and dealing with, to try to navigate the ambiguity of not only the disease and how it looks and presents, but also how we're expected to utilize the tools, work with the tools that we are being given to support management of a contagion. So the first example I will give involves a situation involving testing for COVID-19. And the criteria, as has been mentioned by all the speakers, has been a moving target. It literally has been continually being refined and readdressed and reassessed as more information becomes available, as well as additional resources are being directed towards elucidating what we're actually trying to, what the disease may look like. And frankly, it looks, for all intents and purposes, unless it's severe, like someone who has a bad cold. That is what my colleagues say they are seeing. And it doesn't look that much different than having the flu, which all of us are pretty burned out on right now, as this was one of the worst flu seasons we can remember, particularly for me because my vaccine failed and I had the flu twice. But it's not about me. Moving on. So the issue first that we're finding in real time is, who has a primary authority regarding this? Who do we trust? The information from the CDC has been helpful, but it also, because it's changing, we're getting information from our individual health departments, from our individual infectious disease departments, from the managers and directors in our department. That information continues to fluctuate. And as such, the mental models have been difficult to construct. And there's been some interesting unintended consequences, of which I give you this one. A physician at one of the smaller facilities I work at, it's about a 300-bed hospital, was awakened at 2 a.m. by a phone call. That ended up being a conference call between himself, the chief medical officer of that facility, the CEO of that facility, the nursing director, the medical director for that ED, chief nursing officer, the medical director for that ED, as well as the nursing director. And the question they wanted to discuss with him was that they had heard that there was a patient with coronavirus, and it had been reported that he had failed to test her. He was particularly surprised also when he realized that there was a representative from the legal department as well as risk management on this same phone call. And this apparently, and this is sort of like with SQ, I can give more details in another setting, but it appeared to be the result of miscommunication and misunderstanding of a question that the physician had asked across the ED to the infectious disease nurse regarding when he could do his corona mask testing. And that was misunderstood and misread by some of the newer nurses, that he was asking about not the mask, but about actually doing testing itself. All well-intentioned, but particularly jarring, because it was I thought it was an interesting example when I put my human factors hat on, of the issues related to mental modeling and how can we effectively and consistently provide that for everyone that's involved. The other example I'd like to give a second is regarding the issue that we know of limiting transmission. And it comes down to kind of this idea of who is policing. And I use that word, in quotations, and SQ talked about, putting people in lockdown, which has a draconian feel to these words, but they are being used as descriptors for how we're managing the contagion. In this particular situation, I received an email from another facility, actually quite large, that at 9:20 a.m., the physician group for that emergency department who are not employees of the hospital sent this following email that said, effective immediately, every ED provider now has to wear goggles, gloves, and an N95 mask in every room for the entire shift. Our shifts last 12 hours. N95 mask is reusable by placing it in a paper bag between shifts. Interesting. I was a little surprised because I was like, what's up with the paper bag? What's going on? I didn't know that. Am I supposed to clean it? Shouldn't I be changing masks? I'm not sure. Within 6 hours, there was a repeat email that said that the physician group had stepped back a bit and just said that they were now recommending this following combination of protective gear. And that was because the hospital administration pushed back with questions such as these: who's providing the goggles and how are we defining a goggle? Do safety glasses count? Is that going to provide adequate protection, and how are we going to assess them? Who's going to pay for them? Paper bag, do you mean a real paper bag? Are we supposed to buy them? Are we going to put them in the department? And if the clinicians do recycle their N95, where are we going to store them? Are they expected to store them in their car, take them home, leave them somewhere here in the department? So the SAFES model for this shows that the issues can quickly shift and change depending upon where the emphasis and the pressure is coming from, and who is ultimately considered for lack of a better term, the definitive heavy of the conversation. Who is the person who is, or group is drawing the line to say that this is how we expect this to be managed and practiced, and we're going to be, for lack of a better term, policing it. The last example involves issues relating process adjustments and the large number of competing goals and trade-offs that are overwhelming as we try to manage our shifts and integrate this, like I said, these new procedures into the work. So for instance, radiology is expected to do very rapid turnarounds on x-rays and CT scans. And a CT tech was overheard asking, So if we do a CT scan on a potential COVID patient, what are we to do after that? Are we to shut the machine down and have the room deep cleaned? Are we expected to do it? Is environmental coming? Aren't we exposing the next patient who comes in with a totally different disease process to the virus? Where should we go and what should we do? And additionally, radiologists are feeling a lot of pressure regarding reading of CT scans, and they, how do they prioritize a CT scan from a patient who may potentially have an infectious process due to this virus, and mix all the others that they're dealing with related to stroke, MI, heart attacks, intracranial bleeding, etc. On the ED staff side, we feel quite under siege. The work system is going from, has always in the form of some degree of gridlock or feeling stalled, but we all know that we're going to move from being in the situation where we're with the flu to being frankly frozen once we end up bringing in other kinds of patients related to this infection. And we have a number of time-sensitive outcomes that we're now going to have to trade off. Stroke evaluations have to be performed within a certain amount of time. A patient who presents with a heart attack needs to be mobilized and moved to a cardiac catheterization lab within an hour. Pneumonia patients that are bacterial and non-viral have to receive antibiotics within a certain amount of time, or the organization will not be paid for the patient's visit. Therefore, there are a number of not only our personal health, but also legal ramifications and compensation implications towards adjusting and paying attention to the processes that are in play and the kinds of adjustments that we need to make. So in summary, like I said, I condensed this way down. We're in very early days here, and there's much more for those of us on the front line to have to live through. The question of how can HFE help us, and it's clear that the input is sorely needed for a broader view of how the work system landscape is expected to function under this weight of a crisis. This kind of world event, however, I think could provide us an opening for greater integration of human factors into healthcare. And there were questions I know related to how do we do this? And Terry discussed reaching out, hospital systems and reaching out to human factors. And I would like to offer a counter option as well. And that would be to integrate ourselves as much as possible into after action reviews at a minimum. And that we do this on a gratis basis. Now, this does not mean that I don't think we have to be involved in whole organization evaluations, but we could offer our services as individuals or small groups of professors and graduate students to the pharmacy department of a local hospital to see what they thought and what their barriers were. Not only is it something that, yes, is publishable, but more importantly, it's an investment, and it's in our own expertise and an opportunity to demonstrate what we can offer. I think if we can relay the information effectively and understand how local rationality was vital for especially the smaller systems, or for actually all systems on the front line to deal with the global crisis, that kind of information can definitely support future planning. And with that, I'll end. Thank you.
Okay, thank you, Dr. Perry. We've got a lot of questions, but not much time, so just one short question. One of the changes in systems right on the ground is the initial assessment by telephone and other telemedicine to evaluate patients. So what are the human factors challenges for providers and patients in that change coming into the system?
How to navigate that let me rephrase that. I think the biggest challenge is which level of provider can do that screening. Can it be at the nursing level? Are there resources available for that? Often there's been a default in most of these settings that I've been working in to the clinician on duty at that moment to make those kinds of decisions. So even though the calls are being intercepted by, let's say, a physician assistant who now his or her whole shift is being structured toward dealing with these outpatient calls, ultimately that responsibility for the clinical decision of, should they come in, should they not, should they be tested, should they not be tested, is falling to that physician. So there is we already spend a lot of time in the emergency department dealing with abnormal values from outpatient services. We also field transfers of patients from other facilities and from other physicians' offices. We end up being the safety net and the repository for all that is difficult to manage or takes time to interpret and understand, which most other settings don't have. So I think that as we're moving forward, this is going to be one more source of, to be perfectly honest, frustration and drain as we're still managing our usual populations of pneumonias, heart attacks, et cetera.
Okay, thank you, Dr. Perry. So we're going to open up the questions to the whole panel, and we understand actually that we're at the end of our regularly scheduled time, but we'll go a little additional for those people who are able to, and of course we understand if panelists or attendees need to drop off, but we'll go some more minutes here with some additional questions. So with that in mind, one of the questions that were asked is really how do we assess the risk of potentially changing and conflicting information? I think that's something that's come up in a couple of these presentations. Dr. Perry mentioned it. Dr. Sachs certainly did with respect to mental models. So this is really the question is you might have established some regimen and now new information comes in and then there's some later regimen that comes in and does that create greater risk? And so the overall question was really how that those changes in information may impact things from a human factors perspective and how that applies to HCPs and then also the general population and what we can do about it. And again, that's open to anybody.
Shana, you want to take that?
No, SQ.
I'm trying to stay awake, but what we are seeing is we defer to clinical judgment. In all honesty, we have a study right now to look in how the doctors are reacting to all these changing case definitions and all the different case definitions coming up from different authorities. But what we are seeing in terms of operational approach is really deferring to clinical judgments.
One of the issues around that is somewhat SQ and is the idea in that first story about the physician being awakened at night and second guess. And it turns out that in that situation, one of the nurses who had overheard this had then taken it up her management chain. And as we talk about increasing participation of all team members, everyone having a voice, psychological safety, it was good from that standpoint. But of course, for the clinician, frustrating and to be perfectly honest, terrifying because he's not questioning not only everything that he's doing and decisions he's making, but wondering what the ramifications will be down the line as cases are reviewed retrospectively. Are we going to be given credit for what, like you're saying, SQ, what the clinical presentation was at the time, or will, with the retrospective scope, we be called to task for having missed something?
Agree. No easy answer.
No, none at all.
Okay, so I'd like to shift gears on the question. There was a question asked a while back about, given all the quarantine and the isolation, how can we enable social interactions that elderly people rely on for their emotional health? And in general, I'd add that, how can we deal with the emotional health implications of this kind of now pandemic on a large scale?
I would defer that to SQ because you have mothers, children, other family members. Are there any specific things you guys are doing to support that?
So the what we're seeing success. Okay, besides giving them free Wi-Fi, right? What we're seeing success is there's a lot of human touch. I mean the indirect human touch, right? The some of the handwritten notes or just the I think the challenge is the communication aspect, right? We a lot of things that go into the isolation room either stays there or gets subsequently destroyed. So we just keep that in mind. And what we are doing right now is we send one-way notes, handwritten notes, or we drop by and we communicate over the door, check in on them. But by and large, what we are trying not to do is to treat them as though they are freaks or zombies, or that they are outcasts of the society just because they are they're innocent victim of an outbreak.
Agreed. This is similar to what I remember when we were dealing with HIV, and it was a huge burden on patients and families to reintegrate back into the environment, even if they weren't HIV positive, but there was a perception that they were somehow pariahs, or somehow still infectious or a danger to other individuals. So I think that's going to be a long. I'm not even sure that's come up on the radar yet. It's something we're going to have to start dealing with.
Okay, so another question for the whole panel would be, what are some opportunities for immediate or sort of near-term contribution that human factors engineering experts or our overall community can make? That is sort of what can we do in the next days, weeks, to make a difference?
Don't spread false news, I guess.
True, that's very helpful. As I said, there's a comment on here from Ken Catchpole where he asked a question about whether or not all the hospitals and facilities even knew that human factors existed and could have an opportunity, could be another pair of hands. And I think that's where it could be a benefit, is trying to find ways for us to be another pair of hands in dealing with a problem that affects all of us. This really, I'll just put it on the table, I'll probably get voted off the island, but this is not an opportunity to go make a lot of money. This is an opportunity as human factors, professionals. We also have a professional responsibility to society. And as such, any small project, whether it's, I'd like to go and, interacting with the director for, what do they call it? Visitor services, and offering them your expertise, for free, to help them maybe map out or create a more human-friendly mechanism for navigating, visiting their loved ones. Those small things actually will matter. Where people park now matters. There's some facilities I know in Washington that are having difficulty with, they're concerned about where they're going to put all the cars of anyone that they end up admitting or having to put into quarantine to monitor, because they may feel that this person, as HQ described, they come in and they end up, never leaving, or feeling like they're never leaving. So I think this is an opportunity for human factors to present itself in a different light to healthcare, and then as being a part of both families and both domains, healthcare welcomes those who see our vision, which is to care for people, to minimize suffering, and to heal when we can. So I think presenting ourselves as less as a business entity and more as another pair of hands, volunteers to a larger problem could go a long way.
Okay,
yes,
thank you, Dr. Perry. And also, go right ahead. I just want to thank you, Dr. Perry, and thank Ken Catchpole for posing that question as well. Go right ahead.
I just want to make sure I coin it as the information design of reassurance. I think that is a overarching theme across COVID-19 right now. Is resources is one thing, but the information dissemination is one of the weakest link we're seeing right now. And I think as human factors folks, we do a really good job making information more efficient.
Correct. So I could see that turning into a conversation with a hospital's media department, and saying, this is what we do, that we'd like to volunteer our expertise, no fee, to help assist with this, because it affects the world. It doesn't just affect our business and it affects our families too. And I think that's where this particular pandemic has had a different feel or flavor. The flu we've all gotten sort of used to. expected to, sort of march through every fall. But this is different. This could be anyone and any of us. So anytime we invest is an investment also in ourselves, and also in our families, and our families' futures.
Thank you, Dr. Perry. I actually going to hand back to Tony, but before I do, I just want to thank all the panelists regarding the answers to the questions, and also to say that, there were many questions that were asked that we couldn't get to, but as Tony alluded to, we will be following up on this in other venues. Thanks again.
Thank you.
All right, yes. Thank you to all of the presenters listed here. Again, the webinar is being recorded and will be uploaded to the hfes.org website in a day or two, so check back for that. We won't let the questions go to waste. We will find some way of answering them or integrating them into another session like this to take place at the virtual symposium. Before I talk about that, just wanted to thank Eric and Joe for helping me organize this, and a huge thank you to Alexis from our management company, Smith Buckland, who really organized all of this and got the word out and got everyone prepared and put us on this platform in 48 hours, which is just incredible. So she's been a great resource to us. So thank you, Alexis. Just a reminder that you might want to check out the CDC website and what is called their Clear Communication Index. Thank you, Ernesto, for informing us of this, and I'm sharing this with you here, so you can go on the web to that. And finally, just to remind you, we are going to have a huge Human Factors in Healthcare virtual symposium. We'll be announcing the date within the next week. Email us, contact us, check the website if you want to attend or if you want to present. We're going to have definitely some sessions on health epidemics like the one we're all experiencing. So get involved, join HFES if you're not a member, and be a part of the conversation. And again, thank you for all the attendees. Thank you to all the presenters who took time, didn't have much time to prepare, and then took time out of their busy days, some of whom are actually treating patients and working the front lines. And thanks to everyone for being a part of this. Really appreciate it. And that will conclude our webinar. Again,